Well, good morning, colleagues, and a warm welcome in every sense of the word to you for this public broadcasting. Because it's still a warm room, we're leaving the doors open. I hope that's okay. If anybody wants to close the doors, it's easier closing the doors than it is closing the internet to remind colleagues this is a public board meeting. So I think we'll probably carry on with the doors open, don't you? We've got plenty on the agenda, a lot of really interesting and challenging stuff to work through. I'm very much looking forward to it. But I think I've got nothing to say by way of introduction other than, have we got any apologies?
We haven't received any apologies.
Okay. Have we got any declarations of interest above and beyond the ordinary that we need to declare? No, that's good. Minutes of the last were nice. I'm happy with them. Anybody got any queries, challenges, questions about the minutes of the last meeting? No, that's good. And the action log is satisfactorily straightforward. I don't think there's anything I need to flag up to you. Anybody got any questions or challenges regarding the action log? Good. Can I just check with colleagues, since we haven't any other business at the end, does anybody want to warn me of anything that they're intending to bring up? Good, that's nice, in which case we're already into the first significant action, which is Bijou. You're okay.
So this is the month of February dashboard, and you will see there that we have, in terms of our finance, performed very well this year and within plan. I think operationally we've had our own challenges, particularly around our A&E waiting times, our 18-week performance and our cancer performance, all areas which the team continue to work on in terms of improvement. We have managed this time round to hit our 28-day faster diagnosis measure, which is a real positive, ensuring that our patients who are suspected of having cancer find out one way or another whether they have. You'll see as well there in the bottom corner our patient and staff experience, some very positive results there despite the pressures that exist within our system. And then you'll see in that far corner there the report that indicates the good positioning that the organisation had in the national staff experience. I think in terms of progress, in terms of our strategic updates, Berwick still is on plan currently, and we've made good progress there. And our back to basics work, which is spread across the organisation in terms of getting our fundamentals right in terms of delivery of care. Again, a very good focus, discussion and work going on within that field also. And that was it.
Okay, well that's good and clear, and admirably clear dashboard as usual. Questions or comments on it? Always frustrating when there's still the odd kind of red button, but we know that. We talked about that at some length at Governors last night. Any issues board want to raise at this point in relation to the dashboard? No. Let me just say, Margaret Rowe, just in case I don't see you, feel free to just kind of chip in if you feel that I've ignored your hand, okay?
Okay, thanks, Chair.
Right. Then I think we're ready to receive the dashboard and move on. The next item is listed as Chair and CEO engagement update, and I think it's a useful opportunity. We've had some discussions elsewhere in audit and elsewhere about how to make sure that we're regularly reporting to board on the activities that we're having in relation to the ICB and in relation to the Alliance more general, and to make sure that the board is cited on that wider range of engagement. We will be introducing a regular 3-monthly written update on this, but on this occasion, as we get ourselves started, I just wanted to briefly summarise what I've been doing. I'll give Bijou the opportunity to do similar without boring you with a list. We've always been engaged in the ICB activities. That involves me in monthly meetings with the other chairs within the region and within the provider collaborative, and a monthly meeting with the chair of the ICB and the chief executive of the ICB to look at issues of commonality. There's also now a monthly programme in relation to the Alliance, where the chair and chief executive we collectively meet in the steering group, and I separately meet with the four chairs once a month also. There are inevitably the kind of along the side incidental meetings that take place during this formative phase as we're developing the Alliance. I also look to represent the Trust in meetings in London, so in the 7 months I've been chair, I've attended 3 meetings with chairs and chief executives in London, and I expect that kind of level of contact to continue. Those are the kind of the outward reaching beyond the board. I probably don't need to summarise to you the engagements that I have with the governors, because you attend all the collective council of governors meetings, but in addition I have regional constituency meetings with governors most weeks now across the patch. I think that probably picks up my report on the wider engagement. Bijou?
Yeah, so just a couple more. So I mirror a lot of what the chair does. So in terms of the chair's meetings, there's a similar version of those, particularly around the Alliance and the ICB around chief execs. So they occur really on a regular basis. In addition to those, I meet regularly and have done so this past quarter with both local authority chief execs in terms of making and ensuring that we have a close working relationship, both with Northumberland and North Tyneside Council. Similarly, myself and Alistair meet regularly with PCN leads to ensure that our engagement into primary care, who are also our key partners, are maintained, and we understand some of the pressures that they feel. Similarly to the chair, I met with Amanda Pritchard and Julian Kelly at national level, and more recently with Scott Wilts, who is one of our co-opted governors, but also Professor of Sunderland Medical School, and in particular regard due to the expansion of medical trainees in the near future and what that might mean for us moving forward.
Thank you. That was a couple of things I should have added myself, but the opportunity for you to put any questions or challenges to us in the way we're engaging. Richard.
Thanks to both of you for that update, and I think it's good for us to see the extent and the breadth of what's going on there. A couple of comments from me. I mean, I'm aware from going to the constituency meetings with governors the value of what comes out of that and the real benefit of the engagements, and I wonder if not today but future public boards, if we could just have a little sort of summary of some of the key issues coming out of those constituency meetings, just so we get a flavour of the sort of issues governments are raising in those forums.
I think that's an extremely good idea, which I will take on board and talk about with Laura Liu, to see if we can get a summary. Actually, maybe Ross is here in the room. Can you take that up, please? Yeah, let's think about whether we wanted every public board or whether we wanted every couple or something. Otherwise, there might be an element of repetition. But a very good idea that I like.
Yeah. Second, I was conscious from one constituency meeting I've been to, the strength of concern about dental services in the region, which isn't our responsibility, but in a sense, we are one of the very key few public faces that we've got for people to make those views known. Just reflecting on how we can make best use of that type of input, recognising it's not something we can fix.
So there is, and that has been flagged both at ICB level, but interestingly this afternoon there is a meeting with a place-based meeting for North Tyneside where dentistry is actually on the agenda, and I think our close working between local authority and health has I'm hoping, when we discuss this later today, be able to influence the dentistry provision. This is just for North Tyneside, so I appreciate that something similar needs to be done for Northumberland. But obviously, from a council point of view, members are getting a lot of queries around dentistry, so they're able to lobby the ICB as well from a different viewpoint.
Jeremy?
I just think it's an excellent point, and I make the obvious one that actually there will be a lot of people attending our urgent treatment centres and EDs who should more appropriately being seen in GDP world. So it's a real concern to the region and ourselves as well, I think.
Okay, let's give some thought to this. I'll take Katie first.
Thank you. Just to say that NPC is starting the dental project, so we can see how we can support and incorporate that with NPC.
Good, that's really helpful. So let's log that it is an issue that we're taking the opportunity to be feeding in, but I think we probably need a more strategic discussion at some point. Probably not the most urgent thing for us, but it's very important, maybe at a board development. Can we have one of those open, reflective discussions about what are the levers that we as a trust might have the opportunity to pull around dentistry? It's a really good prompt from Richard as well, because there was a very similar conversation at another constituency meeting around the concerns around mental health. Again, not all issues within our direct control, and neither of us remembered to say that Bijou and I are meeting with the Chair and Chief Executive of the Mental Health Trust in the coming weeks to talk about more strategic engagement on some of these really wicked issues where we kind of all know that the quality of service, not just the service that we provide, but the service out there is not what we would wish for our own children or our own families. Anything more picking up on the Chair Chief Executive engagement? And thank you very much indeed. Let's move into section 2 on the patient and staff experience. We've got some really interesting stuff here. Yeah, got some really interesting and quite challenging stuff here. Joe, you're going to steer us through this. One of the things that I very much welcome in this is that it actually starts with a story that's got some pretty striking criticisms of what we're doing, and I'm pleased that we're hearing them and bringing them to the board. So, Joe.
Thank you, Chair. The stories for board today are the really important topic of food. So, as the Chair has said already, the patient story is not particularly a good experience for this patient in terms of their experience of food while staying in hospital. Particularly a point in the story was the quality of the food in terms of how it was served and when it arrived. Variety, particularly around fruit and vegetables and the availability of that. We're thinking about 5 a day and ensuring that we're promoting good health for our patients. There was not a great availability with the exception of fruit juice, and some of the serving of the vegetables was described as not good. Also, everything was low fat, which again, for people who don't want to be eating artificial sweeteners in terms of choice, a wider choice. When there was a note, and the staff story includes a story from the nutritional assistant, but the patient talks about the difference when the nutritional assistant was there and the availability of snacks and drinks. However, when the nutritional assistant wasn't available, being able to get hot drinks and describes particularly a long gap from early in the morning till late in the evening from having a drink, a hot drink in particular. I think the other thing that they talk about is for them is their reliance on their family members to be able to bring food and drink, and we would know that not all of our patients would have that, so that most definitely is not a default in terms of personal preference either, because not everybody has got that availability and shouldn't rely on that. They did mention though other areas where there has been some really good experiences with food around the oncology day unit in Alnwick, where it felt very homemade, home produced, and also during a stay on ICU. If I move on to the staff story, so we've done 2 stories. So what we thought is that sort of delivery of food on the board, so from a nutritional assistant, and a title that I never heard of in the trust before, but I think is wonderful, a kitchen superintendent. I just thought that was marvellous. So the nutritional assistant, I think I was Richard and I were just talking about the stories, and I was saying we had a conversation yesterday in ENT development about pride, and the nutrition assistant in her first couple of lines talks about her pride in the role that she does and how much she enjoys it. She describes her role at, for me, it seems she's very much part of a multidisciplinary team. She talks to the nursing staff about the nutritional needs when she goes onto the ward, to understand what patients need, what would be helpful, any allergies, any specialisms that she needs to think about. She helps patients and supports them to use the new ordering system to be able to make meal choices. And she works closely with the catering team, so she has twice yearly meetings to understand any changes that are being made, and she just, one of her reflections is she just wishes there was more of her to be able to provide the service. The kitchen superintendent, 40 years experience within catering, part of some, so these are new to me, but Hospital Caterers Association in the North, so bringing together regionally and collectively to talk about experience across different trusts, how they can improve, how they deliver services. Also, they talk about, in the last couple of years, the new systems that we've delivered, we've had installed in terms of the delivery of food. So there's a new system called the Bear Lodge catering system, which is about how we prepare the food, the ovens that we use. Talks about staff, how they've delivered on that and the training that's been required, and also the ordering system for patients, which is called Symbiotic system, which has replaced the old system that was done through the TV system that we had on our wards. And there's been a lot of training involved to get staff to, in terms of their knowledge and expertise and delivery of that. It talks about all the different features within that. For patients, they can look at nutritional value of the meal. They're able to see the photographs of what the meal will look like. They have monthly staff meetings to look at how they can continually improve on the delivery of their service. And he also talks about some of the wider challenges. So I think it's important to remember for the catering team, they're also delivering on staff food as well, and the workload that comes with that, and celebrating the free meals at Christmas, the Christmas dinners and the meals that in January and December that we were able to give to staff. But actually to say that that brings in itself some workloads, but it's really important.
Joe, thank you, that was terrific. Andrew and I had a long discussion about food with the North Tyneside governors yesterday. There was a big turnout to talk about a range of issues, but food in particular. Do you want to just capture some of the points that came out from that?
Yeah, so it was prompted by one of the governor's personal experiences when he'd been in cardiology at NSEG for 10 days. And he said, absolutely outstanding care, absolutely happy with everything. The only thing he wanted to really feedback on was the food, and it really did mirror this story that you put here. So we had quite a long conversation about it, and the governors, all of them that were there, were really engaged with the conversation. So I think it shows that it's something that people really care about. A couple of interesting questions about things like, are we tracking what gets sent back? I need to quite a long conversation about portion sizes, about how it's really difficult, and people feel overwhelmed with big portions, and people feel like they're not getting enough food, and just how difficult it is to get some of that right, and people's preferences. And the governors acknowledged that the choices that were there, and some of them had tried the food as well, and they welcome having had the chance to do that, but they recognise that some of those choices were maybe a bit sort of targeted at older patients, but they recognised that was kind of who was getting meals there. So it's quite an interesting conversation, and a couple of things to pick up out of it, like tracking how much food waste there is they're interested in and around, and some of the recent changes around how much is freshly prepared on the site, and they have quite strong views about that. I think quite focused in on sort of freshness and quality, and maybe a bit less so on the cost, but recognising that that's a trade-off. And I think probably final point was just that their view was that the shorter stays people had, because they got so well looked after in NSEG, and they didn't notice that the food was a bit repetitive, and because they probably weren't having such a great time anyway, they kind of go, oh yeah, that's fine. And so it kind of, it's almost a bit of a sort of halo effect around the care that says the food was okay as well, but anybody that's been there for a bit of a longer time does find it repetitive, does start to raise some of these issues.
I've got a couple of points to make, but let me hold on them to see if there are other comments or questions from the board. Biju?
Just that I think you'll see as well in Joe's dashboard when we talk about the various domains, when we measure on the wards, that food is the one that has ironically dropped down. So I think it's very reflective of what you just said there, Andrew. And I think it's a piece of work that we have tried to tackle in terms of, I think we maybe have gone overboard in terms of there's so much choice that the wards perhaps only give a little bit of choice. So there's so many options that the wards perhaps don't go through all of the options because it's almost too time consuming. So we need to get that balance right, I think. I think just the other bit in terms of the story of Wayne, myself and Ross and Yvonne have met with the catering teams across Wansbeck and North Tyneside. One to say thanks for the January staff food offer, but also to get back from them about what could we do differently, because it's such the January food offer is so well received by the organisation, but we have to be very mindful of the impact it has on the catering staff. And we've taken on board some of their suggestions about how, if we were to do something like that again, one, from now we can plan for that in a much earlier way, but also how we could do it slightly differently so it's not as onerous for them as well. So that's just to say we've taken those suggestions that they have on board. It would be, if it was offered again, slightly different based on what they've told us to what we've done in the past.
In the knowledge that this was coming up, I've been briefed by Devin Kent, who's responsible for Japan, and the additional point that he made is that there's an interface with what we know has been the pressures within NSEC and more widely within the hospitals, and put crudely, when staff on the wards are under really significant pressure, as they have been, it's harder for them to build in the time to talk individually with patients and offer the choice, and so it becomes a more limited choice. I think that is a very valid point. And separate, the point to make is, although we've seen a dip in the patient satisfaction on food, overall, the ratings, we're the highest performing acute trust in terms of what patients say. I think it's the highest. Joe will correct me if I'm not, but it's either there or thereabouts.
We're rated 8th in the last National Inpatient Survey.
Forgive me, I didn't wish to mislead. But we're rated extremely highly. That doesn't remotely undermine the importance of looking at the issues, particularly of people who are in for quite a long time. And I think that is the area where we've got more thinking to do. I'm inviting Veronica from NHFM. Chair.
Yeah, thanks. Well, just to add to that, it's just to say that the issue of the quality of the food, though, is the one that we will take away and really look at, because it's all the reasons you just said about the choice, but there should be adequate choice, there should be the high fat options, low fat options, and definite dietary choice is there. But if when the food arrives there is an issue of quality, then that's something we also need to very much take on board and take up with the companies and take up with the team, so that will be something Damon's on as well.
Thank you, I appreciate that. Jeremy?
So we spent this morning talking a little bit about the patient charter, and I suppose I just would like to try and draw the distinction between food and nutrition. And I think nutrition and the benefits that a healthy diet give in terms of wellness and patient appreciation are really important. So I think going beyond the food offer to what we do to make our patients healthy is, I think, the area I'd like us to encourage. And of course the food offer is very important, but it's also about other things that are done for patients in those terms, wards and snacks and all that sort of thing.
Joe and Nadija.
And the other thing I think as well, that it's not covered in this story, but so we've been doing some work with Sean Pogba and Sue Ewer, looking at food across the board, is around the social aspect of eating as well, the interactions and how important that is in terms of people's recovery. So within the real-time survey, there isn't really the scope to measure in that depth, because it will take us, it's about keeping that survey consistent and concise in its measurement, and that's its success. But what we've committed to is to pilot an annual survey around food, which will allow us, and Sean and Sue Ewer are in the process of developing that at the moment in partnership with others, through our patient perspective provider, is do a big sample of inpatients to say actually quality of food, and then the social interaction, nutrition, look at all of those things and look at that on an annual basis as an organisation.
Thank you, that's really good. Paul, and then I am going to sweep it up with Bridget.
It was just a comment to add really that Jeremy touched upon nutrition and Joe's touched upon the interaction of how we do food. That's one of the streams within the rehab bit of work we're looking at. So we'll already start to talk about nutrition for patients in hospitals, looking at hydration as well. It feeds into infection control issues as well. So just to let people know that that's part of the stream that we're already doing some work on.
And when will we hear more about that, Paul?
I can bring it back whenever you need me to.
At a convenient time. Well, good. Yeah, thank you.
It was just to wrap up on the nutritional assistant post. There's a number of us that sit around this table who will remember that we never used to have nutritional assistants in our wards, and we have invested over time to ensure that everyone does have one. And particularly, I think it came on the back of the hip fracture pilot that we did many years ago, which provided the evidence base that said good nutrition helps, particularly in those with hip fractures. High loading in calories actually helps recovery. So I think that we should ensure that we can protect that very much so across our wards. What the nutritional, and we can see it, I think, in this staff story, the effort and time and commitment that they all put into that post is really quite significant. Much of this is done even on their own time. In terms of, you'll see pictures about how they decorate food trolleys, for example.
Yeah, I love it.
Sure, it's fantastic, and that becomes a talking point when they're going around as well onto the wall. So something that very much should be celebrated, I think.
Lovely. That was a really good discussion, and thanks to the anonymous patient story, because they prompted a really valuable discussion here. It's a real issue. It's particularly a real issue for those patients that are in for longer, but some of the food quality issues are real for however long or short you're in there. We need to remember it, look at it within the context that we are still seen as very high performing in terms of patient satisfaction, but that's never been enough for us as a trust, and it still shouldn't be. We've heard from NHFM that they will look further at the issues of quality arising out of this, and will feed back in due course. We've discussed the importance of nutritional assistance, and the overall rehab approach to food is more than just simply calories. It's much more part of the social opportunities for people to be recovering as well. I suspect we would want to send thanks to Mandy, who's been highlighted as particularly good practice here, and I'll send a card also to Wayne in recognition of the positive messages that have come through. We will hear more in due course on the thinking and the ideas coming out of rehab, and we'll get a report back in due course, let's not fix a date, as to how we've responded to the issues raised here. That's my summary of the discussion. Does that capture the key points? And thank you very much indeed. Let's move straight on, and we're still with you, Joe, the patient and staff experience report. We've used most of the time, in fact all the time,
I apologise, it's a bit of a joke show in the face of this. So just some headlines from the report, because it is a bit of a chunky report this for this board. So headlines, so we've done a 2023 sort of reflection back on performance from our independent provider, which is our Patient Perspective, who measure 2 weeks post-discharge. So across the year for all of the domains, so inpatient, outpatient, and our emergency care, we have maintained a position of staying in the top 20% in terms of our performance across the year. In particular with inpatient, if we look at areas for improvement, it's around waiting for beds and the discharge process, the questions particularly that relate to that. And if we're looking at it from an emergency care perspective, it's the wait, information provided, pain management, and overall satisfaction that the issue was dealt with. And these are the things that we're monitoring through our real-time measurement of ED at the moment, which gives us that more timely feedback on a twice monthly basis. And we've talked about the food already, so I will skip over that, but the real-time overall, again across 2023 and more recently in January and February, we continue to have strong results, with the caveat of food is our lower scoring domain, for the reasons that we've just discussed. We've also detailed the National Maternity Survey. I think that was a really good performance there, 24th out of 113 organisations. But as important to mention, we were also mentioned in a positive outlier report, so similar to the inpatient report when we were mentioned in that positive outlier report. Our maternity services were named as performing better than expected. So I think that's absolutely fantastic news for the team. Our community services continue to have good, consistent, strong performance from a patient experience, with 93.72 patients reporting overall positive satisfaction with the services. I think we should mention though that 3.17 reported a poor or very poor experience. And that's the headlines from the report overall.
Joe, thank you. Just my chance to correct what I previously said. I have said that we were the best performing trust on food. We were the best performing acute trust on food. And that was one. Some really encouraging reports there. Any comments or questions from the audience? Thank you. Commend everybody involved. It's great to continue to see this, but I'm particularly pleased that you continue to highlight those areas where we're not yet satisfied. Thank you. And then should we go on to the National Staff Experience Survey?
So you'll all be aware that the results for the National Staff Survey were published just at the early part of this month. From the perspective of the response, we had the highest response rate in the country, so we had 69% in our group. If we look at our subsidiaries and our bank staff response rates, they also improved on last year, which I think from a staff engagement, if we think less about the number, but the fact that our staff are actually engaging with the survey, that is excellent to see that. We were best in our category for 2 out of the 8 elements, so we are compassionate and inclusive, and we have a voice that counts. We do have to mention they've changed the reporting this year to 2 decimal point, which means that we now narrowly missed out on another 3, we are recognised and rewarded, which you can see the difference is tiny. Staff engagement and morale. And overall, we finished 4th out of 122 trusts in our group, just slightly lower than last year, but still fantastic performance.
Thank you very much indeed. Kate, do you want to highlight anything? As ever, there's some things where we're not yet.
Absolutely.
We'll probably focus on that.
A few points, yeah. So I think Joe and I have had a conversation. I think there's a real key in people that don't ever respond to the staff survey. So there are areas, and we're going to start a bit of an engagement programme around those areas that don't tend to respond, because we really want to hear what they've got to say. So that's one key piece of work that we're looking at. In the national, it was the first year this year that there were 2 questions around sexual safety in the National Staff Survey. So again, we're providing a real focus on the outcome of those questions and where specifically the issues lie within the trust. Again, another reason why we need a lot more people to fill this questionnaire, not just on the sexual safety but on other areas. We had a trust partnership meeting on Tuesday. Staff side really helpfully challenged our actions as a result of the staff survey and timeliness of it, because obviously we've got our next local staff survey in July. So some real key outputs, I think, between now and July of things that we can look at and improve upon, which Joe and I will work on what they are. Because you could write 700 things down that we could look at, but just 2 or 3 key areas.
Very good. Margaret.
Thank you. It was just to say we need to celebrate this. This is an excellent result when you particularly think about the challenges that colleagues are going through, but also the morale of the population around the NHS. This is just wonderful, and a big thank you to everybody, because there's many trusts would be so envious of this type of response. Just brilliant. Thank you.
Well done, Margaret. Kate, you want to come back in and then
Yeah,
go?
thank you, Margaret. I think on Margaret's point as well, to highlight the public board around the bank, because they've had an absolutely fantastic performance, and that's been years in the making in terms of engagement with our bank staff. I just wanted to highlight that performance.
And then HFM and NPC.
Yes, yeah.
Bernie.
Thank you, Chair. Concur, absolutely fantastic set of results overall. But in the spirit of just beyond excellence and continuous improvement, just adding to some of the points Kate's mentioned, it's something through People and Culture we're now pushing with some vigour is flexible working, because I think we were a little bit lower than we would expect to be. So we're on a journey there, but I think efforts are cranking up at pace now to be as flexible as we possibly can in the offer to the workforce. And in terms of the equality, diversity and inclusion agenda, particularly from a workforce race equality scheme, a little bit more progression required in terms of career progression. And in terms of race equality and disability equality, the issue and the ongoing issue of bullying, harassment and abuse, disproportionate impact on BME staff, in particular disabled staff. So that's something in our shop focus through people and culture.
Thank you very much, Joe.
Yeah, I just wanted as well just to reassure the board and just from my perspective in public board to publicly thank the business units and the subsets how they absolutely engage with the survey results in terms of wanting to work with my team to look at the results, look at where the actions, and we've got a whole series of meetings with all of the boards and subsets to talk about their actions going forward.
Okay, so top message. Sorry, I beg your pardon, Marcus.
Thanks. It was just to say on that point, Joe, that some of the results are fantastic, but I think when we talked about in Governors last night, some of the pressures on the Northumbria site, that is evidenced in some of the feedback. So myself and Joe are going to catch up with some of the wider leads on the site, because there's a piece of work there to talk with the staff to understand what else would they maybe do to additionally support. And I just think it's really important for Florida in that as well.
Very good, very good. Top message, congratulations to staff across the piece and all the business units. We'll be even happier when everybody is responding to the query, and then we could always feel a little bit nervous because we don't know what the people who aren't applying are genuinely feeling. People in culture are calling all over this, as they rightly are, and we'll be, in due course, I'm sure we'll be seeing improvements in the responses on flexible working, on appraisal. It'd be nice to see further progress on race equality and disability equality, although we are, I'm glad to say, better than most. The results are still better than most, but that's not yet good enough for us. But really helpful report, really clear summary, and a great encouragement. All good. Let's move on then, and a bit more learning about what's going on. And here we've got 4 board walkabouts. And the first one, Andrew, you in the contact centre.
Yeah, so I asked to go around the contact centre. I guess it's slightly unusual as a walkabout, but they seem happy to have some people to fill up. So I'm always quite keen to do these sort of back office look around as well. So I wanted to go to the contact centre just because it's something that we're talking about more and more in terms of patient portal and the overall experience of patients. So I got taken around by George, who's it was really interesting that he'd moved into that role from having been in more of a clinical environment, working in gynecology at NSAC, I think it was before. And so he was obviously really using that experience of having been on the other side of the fence in the contact centre, so I thought that was really good. And they'd just moved back into their newly refurbished office, directly underneath us actually. And so it was a really nice working environment, kind of had a nice sort of vibe to it, good feel to it. And I'd say that I knew they hadn't even finished yet, so it looked pretty good already to me. I had a bit of a dig about how the move had been and how that had worked, and they'd really taken it in their stride, and they were really complimentary about the sort of IT setup enabling them to do that. So I was fishing, as always, about sort of IT negative things. I couldn't get anything out of them because they'd all got sort of laptops up and screens on the desks and everything, and just working in a really modern way, so I was really pleased to see that. We spent most of our time talking about patient portal, and so that they've had some really good early progress on patients viewing letters digitally and that kind of thing. They're tracking the take-up rates of that, so I thought that was really good. They've done a lot of thinking about how to make sure people aren't excluded from viewing things digitally, so it's good to see. It's still quite early days, but it's good to see that was quite front of mind. We had quite a long conversation about that, but it was good. They've made a lot of use of the new broadcast text messaging, being able to send messages out, so especially for filling up last minute places that may become available and that kind of thing. So that's obviously been a change to the way that they've been working, and that's been really good, and it's reduced the amount of outbound calling that they've done, so that's good. I think the amount of inbound calls is still the same at the moment, but we'll look to see how that changes over time. So that all sounded like it had been going really well, and I asked a bit about some of those conversations and how it's been during the industrial action and other things going on. And they have obviously had some really difficult conversations, and they've actually put some extra training on for dealing with difficult conversations with patients, so I thought that was good that they were responding to that, and it's still something for us to keep an eye on how difficult some of those conversations are, and then the people who are kind of the front line of some of those conversations. Something else that was really positive was around patients starting to rearrange their own appointments and us offering that. So I think that's a real change in how we interact with people. We don't just sort of send you a letter saying turn up at this time at this place and that's the end of it. It's now patients are starting to be able to rearrange their appointments. It makes them more likely to attend. We'll start to be able to offer that through patient portal, and we'll see what the uptake's like for people actually being able to do that themselves. And I think that's going to be quite a big change to the experience. So I think that's really good. And there was a lot of really good stuff internally as well about making some progress with the process automation and some of the efficiency work. So I thought that was all incredibly positive. I guess some things to keep an eye on, just some things that I noticed. They're obviously really well engaged with the different specialities, but it's also a bit patchy in terms of how those conversations take place. So they're getting a lot of really good insight into what patients are saying, which appointments are easy to fill, which less so, and which areas are doing more cancellations within 6 weeks than others. And they've just got a lot of good insight there. It felt like we could do even more to get them hooked in, and I know they're doing a good job on that, but it felt like there's more that we could do around that. So excellent, really interesting visit, really good to see them.
Andrew, that's great. Questions, comments? Marion?
Thank you, they really did enjoy going, so anybody is welcome. Just two things from that. We've now appointed a clinical lead in that area to bring the clinicians more into the contact centre and to have discussions with the wider business units. And the second thing is that I think the flexibility and that we're working with Kate and the team about them being flexible, working from home, etc. has really helped the contact centre. Really has, so really good.
Yeah, I was going to mention the flexible working actually here, but there's a real desire for that, and they were kind of championing at the bit to do more. And I wonder, because I think flexible working in a contact centre environment will be a little bit different from some of our other areas, and probably even some of our neighbours around here have been there's been decades of work done in that industry about how to do flexible working. So I think that's something where we don't want to reinvent the wheel and really kind of pick up off best practice.
Okay.
Thank you. Just thinking about the flexibility point and the flexibility of patients being able to rearrange their appointments, which I agree is a good step forward, and hopefully I've seen a reduction in DNA rate. I think we just need to be also mindful that patients aren't rearranging over and over again multiple times, and then we're actually getting them in their appointment in the kind of clinical time slot that we need to get them in. So we just need to build that into our sort of processes.
There's a limit to flexibility.
Indeed.
Yeah. Good point. Sorry, Jeremy.
Thanks, Chair. Again, a morning spent looking at the charter. This is really, really important to the patients and what they're thinking. And I think it was very clear that when we look at resources, we do often look at our resources and how we apportion those, but it's really clear that they're very interested in their resources and their flexibility and how they use that. And I think it's really, really, so it's a marvellous step forward to just get some control back, but it's the start of the journey, I believe.
Will you see Vijay, or you just pointed now? In which case, that was a really useful discussion. I don't think I need to summarise the conclusions from it there. Pretty self-explanatory. Let's move on to the second one, where Steve, you were at Northumbria in quite a challenging time.
I was. It was mid-afternoon. I'd been a busy night the night previous. Jeremy was my guide, and I think it's safe to say that he took me to all the difficult areas. All the areas that we hear about regularly in terms of performance matters. So I think that's really important. That that's not deflected from seeing it in practice, seeing it in action. So to start off with, the reception area was well staffed, and there were also volunteers on site, which I thought was really great and really needed, given the amount of people. I have to say it was busy, both in reception area and in the waiting area, but it did seem calm and it did seem in control, so that was really reassuring. But was a waiting time of 3 hours 40 minutes being advertised on the notice board. So we went into ED in the blue zone. I learned some new acronyms. So I met Will, who was epic, by his own admission.
More ways than one.
I left with no doubt about that. But that's, I think, emergency physician in charge, a consultant. And what he was very clear about, though, was that, though that was his title, he was in charge, that it was all about the nursing staff. And he wanted to really give a shout out to the nursing team. I think he definitely knew what side his bread was buttered on, he said that several times. And really give a real impassioned play that we continue with the strategy of growing our own, recruiting well, values-based recruitment, really working well. And there's been some team building stuff done over the last sort of year, and he felt that had really helped to bring that obviously very busy and stressed team together. So great culture there. We went across to the ambulance handover area, spoke there to a very tired nurse in charge, been at work quite a long time. And I met Aga, who is in any North East Ambulance Service paramedic, and was recently appointed as a HALO, so that's another new acronym for me, Hospital Ambulance Liaison Officer, I believe. And that looks like it's going really well. It's quite a recent appointment, but the team on the day were reporting how well they thought that was going, and she felt it was going well. You could certainly see that she was kind of chasing down paramedics as they were trying to leave, and she was scooping them back in and just making sure things were being done properly. So it was great to see in practice. Hard to give her the performance pats on the back that we think she deserves, because as we heard from governors last night, two different systems, and we've got a slight difference of opinion in terms of how that performance is doing between ourselves and NIAS, but either way, it seems to be that we're all reporting the success. We went into the red zone, where all the cubicles were occupied, a lot of elderly and frail people as well. Andrew was leading the team. Again, very tired, and talked a lot about the pressures that team are facing in terms of things like mental health episodes, and lots of very elderly and frail people. He talked very passionately about a project he's been working on. I think it was called the Ambulance Diversion Project. It comes in here in this building, I think, and they have a centralised team, and it's about making sure ambulance crews get the best advice about where's the best place for somebody to get the help that they require. He talked a lot about also the difficulties that he thinks that the local care homes operating, in terms of how they feel equipped to deal with some of the circumstances that they find themselves with. And he wanted me to pass on that this sharing of risk and reward, essentially, as the approach to take with care homes. He does feel that too many people get sent unnecessarily to our emergency team. There were people receiving corridor care, but we did see the nutrition assistant and volunteers going around and making sure those people were as comfortable as they could be, and things like delirium screening were being done. It was quite upsetting to see, people perched on the beds at an awkward angle, trying to eat. But it was clear to me that they were very well sighted, that the team really had eyes on them, and their needs were being met, albeit not in an ideal way. Finally, I thought it was a great visit to the surgery ward. Cara was doing about 20 things all at once, just while sitting down very calmly and watching a patient who was at risk of fall, and she was doing that to release one of her staff to get a break, which was really, you could see, making full use of IT, with several tablets, things being brought to her for certain things being approved. And it was great to see somebody so calm managing a very important board. And her story was that she was a student nurse back in the day on that board. She loved it so much she wanted to come back. She stayed, she met a matron, and as I say, she looked like she was doing an absolutely smashing job. And finally, the thing just to point out is that there was a few times that I had the opportunity to speak to groups of staff on my wanders, and I asked them directly about freedom to speak up. And it was a consistent message in both of the staff teams who really wanted to talk about that. They knew it existed, they knew people who had used it, and they would use it again. So I thought that was really reassuring to hear. So overall it was a very reassuring visit, and I thought the focus very much was on patients, even though there was difficult circumstances in the
What a clear story. Thank you very much indeed, Steve. Any questions or comments arising? Feels like it stands on its own, really, but Jeremy.
I mean, it was a really
Tough day.
It was a really tough. I think we had one or two less than 400 in the day before, and we'd only just got back under 4 hours. So it was with some trepidation that I went in. I just sort of really just wanted to big up the NIAS and the integration. With that sort of comment that Steve made, it is that you could very much tell though that there was the NIAS system and our system, and I really would be looking towards that nirvana where not just the staff are integrated, but the systems are integrated and all part of one urgent and emergency care network. But
I think somewhere it'd be really helpful for us to look at that in a little bit more detail, whether it's within FIP or somewhere else, just to analyse the way in which it's working. It's been highlighted a number of times. Can we reflect on that? Yeah. Good. Yes, Marcus. And then I'm going to move us on. We're having a great time, but we're taking up time.
Thanks, Chair. Just agree on the AGA comment that we definitely need to look at that short-term funding at the moment, so we're very keen to explore what that would look like moving forward, and we do think there are benefits of that integration moving forward. So it's definitely something we're keen to look at. Just on the corridor care as well, it's very frustrating not where we want to be. The team are really committed to making sure that people get dignity and respect, so there's a room that's always kept for patients to go into the Zoom to make sure we try and support that as much as possible. Again, that's just really important to the staff in there as well.
Okay, right. I suspect the board would want me to send a little note to those people that Stephen has particularly named, which it's a pattern I've started doing. It seems to go down quite well. So next up, Ruth, you were one thing. I'm going to have to ask you to be fairly
I'm going to be very quick. We did a week, I feel like Greg Wallace, I feel like I went into the factory. I got the outfit and everything was great.
It didn't fit?
It didn't fit, but apart from that was fine. It was really good. It was good to see some really interesting things in practice for us, because theatres has always been the closed door point, hasn't it? So specifically, the comments about stores and the improvements in stores were really positive, because that's something we've seen come through the board. They were incredibly positive about scanning for safety and how helpful that would be to them in the team. So they were all really good things that we've seen come through and go forward. They want a robot. I'll just remind you of that. They all want a robot in one spec. Several people told me. The staff are brilliant, and part of the issue with going to theatres was that we had a culture issue raised about theatres in one spec. So it's confidential about the background, but that was one of the things I wanted to talk about. And Alistair took me round and very graciously disappeared quite often, so that I could just talk to staff members one-to-one about how they felt and was everything okay, did they feel like I'd been dealt with. And that was a really positive response, which was good from my perspective, as I have been involved in it. I've given some Kate a little bit of feedback about disciplinary process and things, and how staff find it difficult when something's happening around them and they don't really know what's going on, and we've talked about that. But generally, it didn't feel like anybody had been unnerved by it. Actually, it was a brilliant atmosphere, wasn't it? They were all so, I've never met so many happy people. Like, whenever I go anywhere, everyone's very happy. But they were a brilliant group, and it was really kind of running like clockwork. Everybody was doing everything that they needed to do. People were coming in and out of theatre around us, and by the time we turned around, they'd been in, had their operation come out, and I was kind of oh, he's done, but it was that amazing, it was that good. It was very well used. I thought that was, I was conscious about, and we use it every theatre. There was one not in use, wasn't there, when we were there at the time. So that was also really good to see, although I could have done with more warning before looking through the window. If anyone goes on a theatre trip, think carefully before looking through the window, that's all I'll say. Yeah, it was brilliant, it was really great. I think culturally it was great, it was really interesting to see it. And I'd seen it before where you got to the drive-in surgical day unit, but I hadn't ever got beyond the door. So the staff were really excellent and they welcomed the visit. Because a bit like Contact Centre, they felt a bit unseen. So it was really good to go and see an area that you wouldn't normally get into. And they said, you can all go whenever you like, but take my advice on the scrubs, I'm looking through the window.
Great. Very good. Questions or comments? No.
Three very quick things, and thank you for going, we really enjoyed it. We have a monthly project board on the back of the unacceptable behaviours, which is going very well. Ernie's part of that project, we met this week, and things are absolutely going in the right direction, aren't they? The second thing is the scrubs was an issue, and collecting the team coming back to dealing with that. They've all been back out, they've been into theatre this last 3 weeks maybe, and I think we're on the right road there. And then we're doing a monthly culture cafe, and this is with more of the staff that are, doesn't matter what grade they are, and that's been done extremely well. And part of that is Kate Stevens, Jacqueline, it's Dave Commersley, and it's Ian Allen. So that's across every age sector.
Very good. Let's take up that idea of making sure that board walkabouts go to places that we haven't previously been and that aren't normally top of the radar. Let's try and do that if we can. Yeah.
And the only thing is about theatre, anybody is welcome, we just need a little bit of notice to Alistair and Ruth Avery so that we can make sure it's planned and time to change things.
It'll be good when we've got scrubs that fit everybody.
You can get your own with a hat.
Yeah, maybe. Phil, you were at Hexham.
Yeah, I wasn't it, Paul? Yeah, I had a really good visit to Hexham. I went round with Chris, the Director of Nursing. One of the things she suggested on the theme of going to places you don't normally go to is whether we should put Halt Whistle on there, sort of agenda for walkabouts. So, I think that would be a good idea. Focus of the visit was Ward 3, which previously was exclusively a surgical ward. Since I last visited, it had been split in half, so effectively half of it retained for orthopaedic surgery. The other half currently being used by oncology, but it's a sort of temporary home for them once their existing home has been refurbished. And on the oncology unit, despite the fact it was only temporary, it was really well set out. It looks like a great area. Food seems to be a bit of a theme today, and I did talk to one of the patients who not only was complimentary about the care, but said the food was really yummy. I don't know whether a sample one is statistically significant, but I should throw that one into the mix if you wish to. On orthopaedics, just discussed in terms of the reduction down to half a ward, if that seemed to work you okay, the answer was yes. If anything, there was maybe a little bit of fluctuation in numbers. Sometimes there weren't many people there, sometimes it was almost full. So managing, it's just a question of whether there's anything to look at there in terms of the flow around the theatre lists, etc. I also picked up on that the robotic assisted surgery project is still ongoing there, so it'll be great to see what the outcome of that is once it's actually finished. Mention was made of the charity sport as well, which has been great. So we've got some specific chairs the charity provided and also noise monitoring. The only noise issue seems to be the macerator, which does make a lot of noise when it's on. So if you put a blanket over it, it would help. My technical solution. I also spoke to the nutritionist back on the food issue, and again, really enthused about the work that she does there and how much care she takes in terms of the patients and everything, so that was good. And on the way out, we had a brief look around the MLU facility, Midland unit. It's a fantastic facility, it really is top notch. It primarily deals with prenatal because although there are some births that come there, obviously the majority do at NSEC. The only slight improvement that could be made is the staff eating facility isn't very large, it's kind of one in, one out job. But I spotted if you knock the wall down between there and the kitchen, that would improve it immensely. yet another technical solution. I always like to add some value.
Okay, we've got some extra jobs for Phil to do. That was good and clear. Any questions or comments or reflections? Good, that was a great set of reports. It took up more time than we allocated, but I feel like that's value for money, that was. So thank you very much indeed, all those who have done it, and we'll look forward to the next set of the next public meeting. Great, let's move on. Mike, welcome. I do think you've got the best job title of anybody, Guardian of Safe Working. I think that's, I know you've got a couple of other titles as well, but your reports for us to know.
Great, thanks for the welcome. I like to think of it as the Guardian of the Galaxy. I'm not allowed to put that photo on as a copyright. I've been given a brief to be brief, which I've been told has gone to everyone, not just singling me out. So I'll do my best.
Particularly focused on you.
I did think that might be the case. I don't know where my slides are.
Just keep clicking.
Keep clicking?
Yeah.
Quite a lot. Okay. There's a lot of danger on these slides. I'm glad I missed that.
There you are.
There we go. There we go. So it's nice to be here in person because I've missed the last two board meetings off on holiday. Jeremy, I'm sure did a great job. So it's good to be back. It is going to be pretty brief because that's a reflection of things are going pretty well in the safe working world, despite all the pressures, despite the strikes. We've seen, when it comes to exception reports, a reduction this year, which in one way I think is that a problem, but I think it's probably accurate because with the drop-ins and with the feedback from the postgraduate doctors, I think in general things are working quite well when it comes to safe working, when it comes to our rotas, despite the challenges, they're being managed well. No change in pattern, the majority of our exceptions still in the medicine business unit, but no hotspots. We get these hotspots that pop up and then we deal with them, so Obs and Gynae had a little surge in exceptions the last time, and putting in some changes to the rotas made a difference. But the majority of them are still had to stay late because it was busy and I got time back. Sometimes we pay them if they can't get the time back, but it's the majority time what we do and the majority in medicine, and that hasn't changed. It's hard to make it exciting because it hasn't changed now for a long time. Where we have had some real progress is the Postgraduate Doctors Forum. This was an area of challenge. We had really poor attendance at the forum through the pandemic, which was understandable. Coming out of the pandemic, that continued. So we had some roadshow events, roadshows and then a launch event in March last year. And since then attendance has improved significantly. We've hit our best ever pre-pandemic was 30 doctors or 31 or 2 doctors at a forum. We hit 32 in October and 20 at the last forum. We've got one next week, so I'm hoping we're going to get good attendance there as well. No particular things from the last forum, the usual issues with rotas, and it was a January forum, so Christmas had been a challenge across some areas, particularly lots of bank holiday working, but generally good feedback from the postgraduate doctors. And that, going on to that, we've done a discouragement survey. I think it's the 4th survey we did earlier this year. Not as good a return rate as we usually get. We only got a 10% return rate. We've got about 340 doctors on the contract, and I think we've got about 35 returns. But only 2 returns reported any discouragement, which is much better than previously. We've got more doctors on the contract.
Can you just explain discouragement?
Yes, so when you look at exception reporting, what doctors are able to do is if they consider there to be a safety issue, or they've worked longer than their hours, or they've worked in an unsafe way or not got an educational opportunity, they can report that through an electronic system. And there's always a worry that other staff will discourage them from doing so. So it's effectively consultants saying you shouldn't fill in an exception report. And 4 or 5 years ago, there was reports from, I was at national conference, and there were a lot of places reporting this as a big issue. And I thought, well, that doesn't happen where we are. We don't do that. But then someone said, well, how do you know? So we did the survey. So we did the first one, we had much less doctors on the contract, and we got about, I think it was about 12 reports of discouragement, 12 or 14. So we've done it every year, year and a half since, and it's come down. So that's really nice that it's 2 this time. I couldn't believe it, to be honest. I thought it was going to be more. Every time when I say direct versus indirect discouragement, sometimes they report some of the myths around it. You shouldn't do it. It'll be frowned upon. I'm a professional. Why should we count hours? That's their perception. But sometimes people are actually reporting someone told me not to do it. And we had one of them, only one. So that was encouraging, I thought. So we'll repeat it again. We won't stand on the laurels. We'll do it in a year or year and a half again. But I was really pleased because waiting for the results is a bit nerve-tingling, just in case. So that was good. We've got some ongoing work through the forum. We're going to doing another survey looking at rota issues to just try and get some data as what percentage of the doctors have had rota issues over the last 12 months or so. I suspect it's going to be 90 to 100%, but it'll be interesting to get some data through the survey. So we're going to do that. Bringing on to rotas, our rotas are fully compliant on paper. We've got some wriggle room still as part of the COVID response. That hasn't been taken away yet, so doctors can do some extra shifts as locums if they want to. They're not pressured into that. But we do have rota gaps. It's mitigated by us being popular. We're a popular place to work in the region, and we don't have as many gaps as a lot of other trusts. We also don't have as many exceptions as a lot of the other trusts. And then there is one trust in the region who's had almost no exceptions recently, which is even worse. They've got a non-functioning guardian system in one of the trusts. So the regional meetings are quite useful to get that balance and that sense from other trusts. But our gaps are not as bad as others, but we're managing them well. And I think that's me.
Right, that's great. It sounds like as soon as you go on holiday, the results get even better. So there must be a lesson in that somewhere.
Yeah.
I suspect that the board will feel that we want to just put a message that I'm glad there's only one direct discouragement, but that's one too many.
We discourage discouragement.
Yeah, I think that's what the board thinks, and let's record that. Any questions or comments from that? Yes, Kate.
I think just the encouragement of people to fill it in, because the 10% is really
Yeah,
low,
that's right.
isn't it? So any support that I think Joe and the team could potentially give, and pushing it out a bit wider, I think, because the more we get, the better.
Great. Then I think, Mike, thank you. You've asked us to note the report. We've noted it, and we've underlined the desirability of having more than 10% response, and the board's clear view that we are against discouragement. Thank you very much indeed, Matt.
Thanks.
Welcome. So let's move on. Welcome to Kirsty for the Freedom to Speak Up update. Sorry we're running a little bit late. You've already had a good press this morning because in 2 of the board walkabouts, the NEDs have been speaking to staff and asking staff about their understanding of the Freedom to Speak Up process, and it's been getting very good feedback. So that's an encouragement. This is going to be a referral, isn't it? Because there's been a lot of discussion at people in culture. So an update to keep us all in the loop before we have a full discussion in about a month's time. Kirsty, over to you.
Thanks, Paul. Yeah, thanks very much for giving me the chance to come back again to follow up the terminology, speak up, listen up, follow up. So it's about the report that came out in January, the Freedom to Speak Up report. It was highlighted at board that there was a request to look a bit of a deeper dive at the detriment theme. So quite timely in the national picture also, because it's a conversation we're having as guardians nationally, regionally, within our networks, recognising that we're 7 years down the line with the journey. So whether it's good, bad, and indifferent that you've had me for the same guardian for 7 years, like pros and cons. It gives you the opportunity to understand the journey. So we've had success with the speaking up element, we've had success with the listen up, and I would say we're in the journey of the follow up. So I think from my perspective, 132 cases last half of the year, to receive 35 of those to say that they're suffering detriment for speaking up is a concern, and I'm pleased that you've recognised that it's something that we want to understand and work together more to understand that. So we've had quite a lot of conversations, we've got a lot of work going on in the background, different services involved, just to try and kind of see where improvements can be made. So out of the 35 cases, we're reassured that we don't have anybody that's not being listened to and not being supported within the Freedom to Speak Up process or within one of the HR processes. We've got, there was about half of the staff that reported to myself had also reported to HR, so it's good to see that those communication links are happening. It's then what do we do with the cases that we're trying to kind of understand, so the cases that only come to myself for that support and advice, what happens to those people? So it's forget the numbers, it's the people. So, is it that people move out the organisation and then come to me to raise concerns? Do they wait until they've left to raise it? Is it the reason they've raised the concern, the reason they've left? So with Kate and the team, we're trying to understand the depths of that information. So it's working in progress at the moment. I think it's interesting to see, often it's forgetting sometimes my role sits very independently within the organisation, and I work to national guidance, recommendations, and it is recognisable for myself that we do have some different guidance sometimes with what National Office wants us to do, what NHS England wants us to do, what CQC wants us to do. And I think sometimes that's played out within the trust and within the guardian role with yourselves, with other managers. So I think it's a journey that we're all on together, and I think it's the learning that we can take and the actions to support each other through it. So it's just having that openness, transparency, keep going, keep doing what we do well. We always like to think we're ahead of the curve. We've always, in most areas we are, outstanding. The Speak Up results were no different this year. The national survey results, we were top again. We are doing things well, but we've got an area of detriment that we haven't really addressed, and we're now looking at that. So, thank you.
Kirsty, excellent, really clear update. Questions, comments? Okay.
Thank you, Kirsty. I think that's really clear. I think just an assurance to board, we're taking this extremely seriously in terms of the cases that have been highlighted as receiving detriment. There's a lot of detail to look at behind those, because there are cases that Kirsty did allude to that have been resolved through different processes. And there's assurance that Kirsty gave as well that we know about them, we just need to look at them and a bit of a targeted approach about are they happening in certain areas and why, and we'll look into that in great depth. So we're working on the dashboard together and hope we have that to bring back to board.
Excellent, and it's complicated stuff, because I was fascinated to discover that I think 5 of those 35 aren't part of our trust. They're people that come to us because we're meant to be really good at it, but they actually work for other people. So, yeah. Really helpful. This is work in progress. We're moving from a position where we are rated as outstanding in our freedom to speak up, and we keep getting assurances around that. But as ever, that doesn't mean we've got it all quite yet. We're working on it, and we will bring the results once we're confident that we've got what we need. Kirsty, thank you very much, and a good presentation. Good to move straight on. Then we're into, now this is an interesting discussion one that we wanted to have. There's a bit of controversy out there, not so much controversy internally, I think, although we may discover that I'm wrong on that, but this is becoming a kind of a public issue out there, the role of physician and anaesthesia associates. And Jeremy, you're going to talk us through, but you brought your gang along.
Yeah.
Well, they're not my gang, they're our gang.
Okay, our gang, thank you.
But thank you very much for a team coming from ambulatory care with some physician associates. I'm just going to introduce the topic if someone clicks the button. To talk about physician and anaesthesia associates, and the reason they're topical at the moment is because there's just been the Parliamentary Act to move regulation of these two professional groups to the GMC. That's all now been passed through the House and the Lords and should become enacted during the next year, though I'm not quite sure how the election will pay into that timescale. And that will allow those professionals who aren't registered to other bodies to become prescribing clinicians for the first time. So they're part of the medical associate professionals and have been in the UK since 2003 and 2004. I just want to say that we recruited as part of the anaesthesia campaign 2 anaesthetic nurses from Switzerland, and the first non-medical anaesthetic was given by one of them at Wandsbek General in 2003. So we've always had a bit of skin in this game. They are different from people who undertake advanced clinical practice roles insofar as those roles, and I'll just explain a bit more about them, those roles come from other professionals who are registered to nursing or physiotherapy and that sort of thing. In 2023, there are 160 anaesthesia associates and 1,500 physician associates in the NHS, compared to 134,000 doctors at the time. Those are the numbers for England.
About 1%.
Yeah,
About 1%.
yeah, small number, but I'd like more. Part of the NHS long-term plan, they're very much part of that. And there is a number that is said to double the medical student numbers up to 15,000 a year by 2031, and the medical associate professionals, there'll be 10,000 physician associates and 2,000 anaesthesia associates by 2036. So we've got 31 of anaesthesia and physician associates working across a number of areas in theatres. There definitely will have been some working at Wandsbek when you were there, Ruth. We have quite a number in MPC and quite a number spread in various locations around our emergency admission pathways. In terms of the ACPs, we've currently got 44, but those numbers are due to double with a cohort of about a 50% increase with 48 trainees. So I'm really proud to hand over to Sean. He's going to tell you a little bit about what he really does.
Sean, welcome.
Yeah, I'm Sean. I work on the ambulatory care unit. I've worked there since March last year. Previously worked in Manchester Royal Infirmary for 5 years prior to that as a PA. So background, like I said, first introduced in 2003 based on a previous US model that had been in place since 1960. Work within a multidisciplinary team. It's a 2-year postgraduate degree or diploma. My one was a postgraduate diploma. I think they've switched more now to doing degree and masters, which is the more modern way of doing things. About 57% of people who do it have a previous background in sort of healthcare, nursing, physio, majority or have a biomedical science based degree, or I think Georgia, who's my colleague here, has a physiology degree, so it's usually a healthcare related science degree prior to that. We're dependent practitioners, but work under the direct supervision of a named consultant. As of the PA census from last year, 3,240 PAs nationwide are on the voluntary register. I think of them 1,500 currently practicing. So PAs in general surgery, 3% of the PA workforce currently works sort of within general surgery, but there's various other roles sort of within trauma and orthopedics, vascular, obs and gynae, urology, colorectal clinical services. They work in a variety of settings, myself and Georgia, in admissions or assessments, as well as clinics, some were ward-based theatres, and 10% of PAs last year were part of an on-call rota. Obviously some PAs work sort of across a variety, so in Manchester I work sort of wards, clinics, theatres, sort of a bit of an adapted role. Variety of competencies from our training, so ability to take history, examinations, diagnosis, management, as well as patient education. You can get trained in sort of minor procedures such as bloods, cannulation, venous gases, NG tubes and catheters. As you sort of develop within the role, there is an idea that you can sort of build more advanced skills such as performing minor operations, chest tubes, drain insertions, some ultrasounding, suturing, as well as assisting in theatres. And that's all dependent on sort of your years of experience within the sort of training and support you get within that role department that you work in. So currently in some of the limitations and considerations are we haven't got a national regulation, like I've said, that's just came in February. According to the PA website, it's expected to be in place by the end of 2024 with no sort of setbacks predicted. That does limit it, sort of what you can do, so you are unable to prescribe medicine, fluids or ionising radiation currently. You're also limited in terms of certain courses that you can get that can be useful. So, for instance, in surgery, first assisting courses, it's sort of a recognised qualification. You have to have a PIN number, sort of recognised GMC number in order to get on these courses, or nursing number. So without that, we're unable to actually even apply for these courses. There's obviously the recent increased spotlight and opposition to the role with sort of questions about the scope of practice or the scope of sort of supervision that we have in a flat career progression. So when you qualify, you're a band 7, there's currently no further sort of advancement in that. So it can lead to a bit of inertia or stagnation. So the next steps, like I said, is we're expected to have regulation in place by the end of 2024. There is emerging opportunities, so there's looking at the Freedom Hospital, for instance, at the start of this year had a rollout for PAs to be trained up over a 2-year intensive endoscopy training in order to build it similar to sort of the way nurse endoscopists get trained. There's also rules emerging in dermatology doing minor ops, breast surgery and plastic surgery. Sort of specialised training pathways to develop experienced PAs and sort of better utilise pre-developed skill sets. So again, looking at things like getting PAs on first assisting courses would be useful, so they can be sort of more easily deployed in other areas, and just general career and personal development opportunities that hopefully will come with regulation.
Sean, that's great. Really, really clear presentation. We were keen to get a greater understanding of where we are in this wider debate, and you and colleagues have clearly helped with that.
I was just wondering if Sarah, who has put Sean forward, just wanted to comment on how it all works in our.
Sarah, if you do come and take the mic.
Hi, my name's Sarah Robinson. I'm a surgeon.
Speak right into the mic.
My name's Sarah Robinson. I'm a surgeon working in the trust. Sean and Georgia provide an enormous amount of benefit to us, the surgical team, particularly during the on-call. I think with the public problems that are going on in the press at the moment, it gives a very unfair and skewed view of what's actually the reality of what's occurring. With Sean and Georgia, we've got very experienced colleagues who we've worked with very closely for several years now with Georgia and then 2 years with Sean. And as a result, they've got an understanding of our expectations and vice versa. Whereas when we get brand new junior doctors coming to us or we get new nurse practitioners, that isn't established. And to my mind, they are as valuable as any other member of the team, and I fully support them in what they're doing. Ambulatory care would be a horrific place to work if it wasn't for these two guys who put in a huge amount of effort and are very, very skilled in what they do. And I think it's terribly disappointing that there hasn't been the national support for them. I have no concerns over them. Like all things, not all doctors are excellent, not all nurse practitioners are excellent, and consequently not all physicians associates are excellent. That's human nature, but I think the conversation has been along the lines that they're never allowed to make a mistake. They have to be utterly perfect, when none of us are, and I think that the discussion over it has been very skewed, and we need to be mindful of that. it's been a really unpleasant time for the Physicians Associates in our trust as a result of the conversations that have been going on nationally. And I think we need to be very mindful of that and the impact that it has on them psychologically.
Sarah, thank you. Bijou?
So I think it's just worth noting as well that both Jeremy, Alistair and our business unit, Simon, they have written formal letters in support of this organisation to Physicians Associates and ACPs as well.
Good. Any questions or comments from board? Alistair and then Alan.
Just really to back up everything that's been said, certainly we've got a number, as you can see, working in MPC. It's slightly different in that they've got more of an undifferentiated pathology that's going to them, but their training includes management of undifferentiated pathology, and I think some of the recent publicity restricting that actually is counter to the training that they have. They have a very much more of a medical style of hypothesis deduction training than the nursing model, just in terms of the philosophy. And I think it's really important that we do support them in all of the aspects of the organisation that they work.
Thank you. Alan.
You just did a general comment. I mean, it's fair to say that there's almost a civil war going on in the Royal College of Physicians. We've had emergency general meetings, all sorts of things, a lot of stuff coming through to the fellows. The one thing which seems to be the main bugbear is coming from the medical trainees who see physicians' assistants as taking away the learning opportunities for them. And that seems to be the thing that people are focusing on now. Over the last few years I've talked to Jeremy about this, and when he's told me what they do, the terms and conditions that they work under, particularly supervision, I've always been content that here we're doing it right.
Thank you. I've got Margaret and then Kate. Margaret.
Thank you. Just follow on from Alan. Yeah, I've looked at this a few times, and a great and interesting presentation. But it's the regulation. We've been here a few years, that it's going to go forward. But the thing I'd be really interested in is the impact these roles have taken. So in the future, it'd be really good to see not only what they're doing, but the difference that they're making, if at all possible.
Very good. Very helpful. Kate, your points. Jeremy?
So I just wanted to come on the training, because back in 2003, it was very interesting. We had a couple of anaesthetic trainees who are now consultants who work with us, one of whom actually sponsors the whole scheme. And it is a real issue of concern to the trainees, and I want to say of concern to us, is that when we do work hard to make sure that actually the training experience of both sets. So I think that is the genuine bit of it. I don't think that's going to go away. It's important we train our doctors properly, it's important we train our physician associates properly. And overall, as they go through that, those consultants come to realise that they're an absolutely vital member of the team that actually enhances the training experience on the whole of our training population. Completely have my support.
Sarah, and then I'm going to sum up.
Just to echo that, and I think it's quite naive to suggest it does impact on the training. It is absolutely the opposite, because it allows myself as a trainer to have some more headspace, because I know other work is being done. It's supervised, I'll assess the patient's things, but it's all work that has to be done, and I can't do it all. And if I am doing it all, then I can't have the time to train. And trainees increasingly want to focus on whatever works for their training rather than service provision, and at the end of the day we can't be naive and to suggest that the 70 patients that come through ambulatory care to be reviewed can all be seen by a consultant, for example. We need to have a differentiated work.
I'm afraid I don't know your name at the back, but I want to invite you to say something. Or Georgia. Do you want to add anything, Georgia? Just move from that.
Thank you. Just in terms of training, I think we are very much team players. We're not trying to take away from anyone else's opportunities. And in fact, it's almost, we're actually helping some of the training as well. We've got a lot of new training nurse practitioners that come through ambulatory care and around the trust in general through rotations and things. Also a lot of medical students come to ambulatory care. or even if the junior doctors are coming down to help and don't necessarily know kind of the logistics or quite how the system works, we're always there to kind of provide that continuity of care and help anyone else that needs it really. Yeah, we're not trying to take away from any of them.
I know that, you don't need to say that, even Georgie. But no, they're not going to come.
I think it's probably worth also adding I would say the alternative roles in its broadest sense has been a strategy that the organisation has embraced about how we broaden our view in terms of different kinds of roles that make up this organisation, and I think that has really started very early on, as Jeremy's alluded to, and we've understood the benefits that has, both in terms of the organisation and delivery of care to our patients, but also within our wider communities and the opportunities that offers local students and people in both Northumberland and North Tyneside. So I think as a direction of travel, this trust is very much committed to supporting all alternative roles.
Well, I think that's the conclusion I'm about to reach on behalf of the board. Let me just check in the normal way. I'm going to try and summarise why I think we are, and then come back and challenge and tweak and add. Number one, we're lucky to have you guys. They're valued roles. They've been roles that have been valued by the Trust as part of our approach to diversifying the way in which we respond to need and pushing the boundaries of outstanding practice. And I think we should affirm that that is still our policy position. As with all staff across any part of the organisation, it's important that we monitor the training, important that we supervise quality, and important that we have a clear progression opportunities, career development opportunities, as is the case for all staff. So that's not special to the associates, but it's clearly going to be particularly important at the moment. I think it's unfortunate that the public debate is being, I think the impact on associates has been impacted by the rancour around so many of the industrial action related debates, and I think the associates are kind of collateral damage in some of this. But I think we should reaffirm our commitment to it. And let's pick up on Margaret's point as well in due course at some point. Let's hear something more about the outcomes from this. What can we demonstrate? The gains and any challenges as well, but a rounded approach to the outcomes of this approach. But that's where I think we are. Can I check? Does the board feel that that's our board position? Thank you very much indeed. Well done. Thank you, colleagues. Then let's move straight on. We're into learning from domestic homicide. Who is Jimmy? And Kirsty is here. Domestic homicide reviews. Had more of them than hot dinners in my time. So this one's from quite a long time ago, isn't it?
It is. And just to say hello, my name is Kirsty Shotton. I'm the team lead for Safeguarding Adults at Northumberland Healthcare Trust, and I'm here on behalf of Polish Advocate. So who was Jimmy? So Jimmy was, and I think it's really important that we put this up because we can see the difference between when he died. So Jimmy was a son, he was a brother, he was a dad, he was a grandfather. He wasn't what he was predicted to be. He had a learning difficulty, he had some mental health issues and some alcohol issues, but it's important to see the differences between the two. So his so-called support network, and it's quite interesting when you look at this, is they were a group of 4 people. The guy who was called Zahid Zaman, who you can see there on the right-hand side, was classed as a Svengali type figure. He was in the media, and all of this is in the public domain. The media class this is a bit of a cult. So he controlled everybody within that family, because that's what they were, they would live together. And Zahid Zaman, as you can see, is in a wheelchair, but he wasn't disabled. He didn't need a wheelchair, but his ability to coerce and control people was as such as that he controlled all of them around. On the top next to him is Anne Corbett. She was a victim as well as a perpetrator, and the 2 women underneath both worked in the caring profession, so were carers as well, so that's what we see. So it's interesting to look at this They were well known in the community, they were well seen. So Jimmy was unfortunately murdered by these people, horrifically so. If you Google that, you can see his body was dumped in shrubland near the Townsend trading estate. So when he was murdered, they looked at, there was a review, and they decided to do a domestic homicide review because he was murdered by people that he lived with. He was allegedly in a relationship with Anne Nesbitt, so they looked at it that way. So when the commission, as we were saying, a domestic homicide review, that they look at everything, all of the agencies that were involved, and what did we do, and what were the themes and the learning, because it's all about learning, it's not about blame, it's about the themes. And what came out was, where was the community? He was hidden in plain sight. Everybody knew, besides the man, he was a very sort of charismatic character in the community, so the community all knew that Anne and Jimmy were living in this house. Where were services? We all knew this. I worked in safeguarding at the time, and we all knew Anne. We all knew Anne, and we all knew Jimmy as a perpetrator, not as a victim. So where was the professional curiosity? Where did we then ask that question, where is Jimmy in this? Where could he seek help? Because he was seen as a perpetrator. And there's that stigma attached to somebody that's seen as a perpetrator. So where could he seek help? And where was the support at that time for men who were experiencing domestic abuse? Bearing in mind, professionals didn't feel that he was a victim. So it did take a long time for it to come out, for the report to be reviewed and to come out into the public domain. And it's interesting to know that we have a number of ongoing domestic homicide reviews, safeguarding practice reviews for children and adults, which we can't discuss because they're not in the public domain. Domestic homicide reviews go through the Home Office, as do the children's practice reviews, but safeguarding adult reviews don't, but there's some that's going to change. So when we looked at our the multi-agency, and then we looked down at our own agency, we noticed that there had been no safeguarding referrals across lots of trusts because he was seen as a perpetrator. He was never seen alone, he was never asked a question. As I said, seen as a perpetrator. There was lots of missed appointments with lots of different agencies, not checked up. He was open and closed to services because of non-engagement. And I think we see that now. If somebody doesn't engage, well, it's got capacity, presumed, we don't move on. He was known to police as a perpetrator, and he was also known to Marek. So Anne, who was his girlfriend, often made allegations of domestic abuse and that Jimmy had raped her, and it went through to the Marek process, which is the multi-agency risk assessment conference for people who had high risk of domestic homicide, which Anne was seen as a victim of, without actually thinking who was Jimmy and where was Jimmy in this, and he was the victim as well. So a lot of the injuries that were perpetrated to Anne weren't done by Jimmy, they were done by the others. So the trust learning for us was that, again, when he presented to the agency departments, bearing in mind this is 8 years ago, he was never asked about his wounds, or there was never that professional curiosity. Tell me about what's happened to you. Why have you fallen over? Why have you got these bruises? He had significant dental decay, significant teeth missing, and he didn't go. Nobody asked the questions of why or what happened, bruising on his face. So no conversations around that. He was known to the community LD, T team, and they did go and do knocks at the house but didn't get any answers, and then there wasn't a follow procedure for that. So where are we now? Well, this is 8 years later, and the learning was done fairly quickly, I have to say. And there's been huge developments within our trust, and actually, as somebody that works in our safeguarding trust, it's been a privilege to work within that. So in 2016, we got some funding from the Police Crime Commissioner at the time, Vera Baird, and it was to look at through health, because there was a paper that came out called The Cry for Health, and it looked at and it identified that victims of domestic abuse are 10, 15, 20 times more likely to disclose domestic abuse to a health professional than anybody else. So at the time we got some money, and it was myself decided what we were going to do with that money. We had constrictions around it. So we decided, and I developed a pathway that's in there now, of having a domestic abuse health advocate, based in ED and looking at gynae and maternity because we know that they're high risks, but also to look at males. So we had that funding because it crossed Northumberland and North Tyneside, and we implemented that. So we now have an IDVA within our team. We also have the same person as an ISVA, so the same role but for sexual violence. We've also got another IDVA in the team, and we weren't the first in the country. I'd say that we're first in the country, but we weren't. We were about the second in the country, and as part of that role of looking at how we did that, I went and visited other areas and I implemented it, a bespoke programme. So we now have somebody that's in the trust. So our pathway process is used in South Tyneside, it's been used in other areas within the country. When that funding ended, we approached the executive board and we had the evidence to state that our domestic abuse training is mandatory for all staff, level 3 safeguarding. So we came and we put a business case to our executive team because we wanted to make that role permanent, and they listened. And that role is permanent now within the trust. So we have a dedicated domestic abuse health advocate that will support patients, but not only that, will also support staff who themselves are victims of domestic abuse, because that's really important, and that was one of the things that we wanted to get away. So I just wanted to highlight that, very proud of that. So we've strengthened everything that we've done around domestic abuse. We've got a real focus on male victims, and we've got a domestic abuse champions network within the trust, and we are really keen to recruit males into that, because yes, it is seen as something that is shameful, and it shouldn't be. We know that it's 1 in 4 women, 1 in 6 men, I would probably say 1 in 3 and 1 in 4. We've reviewed the SEED LDT no-reply guidance, and the issue is could we look at, should it have been a safeguarding adults review, because he did fit that threshold because of the vulnerabilities that he had, but I think it was more powerful to come as a domestic homicide review. The only downside to that is how long it takes a domestic homicide review, and it's a process and a pathway that we have to follow. And we have a number that are ongoing, and I have to say more than I've ever seen in my years in safeguarding at this moment in time, because of the complexities that we see, not just domestic homicide, children's practice reviews and safeguarding adult reviews. So I've whizzed through that. Any questions?
Yes, that's great and really clear. Alan?
Could I just comment on this? When I sit on the safeguarding board, it was me who suggested that we should bring this to the board. This is not something that's happening in the south of England or Scotland, just out there, right under our noses. I think it's very informative, very scary, and we all need to be aware. There's good patient stories, we're starting to have bad news stories. This is another bad news story, which the team are fantastic and put a lot of really good things in place now. So it will happen again, but it's much less likely to happen again.
I think it's interesting to know is, in again, when you get a practice review or a domestic homicide review or safeguarding adults review, the learning is always the same, and it always comes, and it's been the same. I've worked with safeguarding since 2008. What we were getting out of reviews then is exactly the same as what we're getting out now, so the learning is out there. So how do we move this on? How do we change that learning? And it's consistency, consistent approach, because the learning is lack of professional curiosity, poor resources, lack of communication, lack of information sharing. And we need to have things in place, but we need that consistent approach. And I have to say, I've worked for a lot of other trusts. This trust is excellent, and I know bang on the drum, but I think the support that we get off the executive team and Fallon is amazing, and I think
That's good to hear. Let's hear Chris and then Bernie.
Yeah, so this very much I think links back to the previous conversation we had around the walkabout cobalt at the contact centre around the patient portal, and about that, the possibility for patients, for people to put off their appointments, to not come, and it's that safeguarding thing that we talk about there, isn't it? And then that kind of, well, we've got capacity, therefore it's their choice, Great.
That's a really insightful extra comment. Thank you. Thank you. Bernie.
Yeah, thank you, Chair. Fantastic presentation, and thank you for coming along. In a previous role, I worked closely with Debbie Arabet and implemented some of her policies on domestic violence and domestic abuse in the workplace. So just really as a reminder to the board, we will have hundreds of people suffering domestic abuse and domestic violence in our workforce. So we've got to have this professional curiosity, yet we've got great support mechanisms coming in place with policies, but we've just got to keep mindful and attuned. There will be hundreds of people suffering.
Powerful point well made, and I think that's one of the biggest points really. Also as an old hand of safeguarding reviews and homicide reviews, and you're right, Kirsty, to say that basically all the generic conclusions are always the same, and actual direct actions, you don't really learn them from bad cases. Bad cases make really bad law. The top issue is professional curiosity. So it's not looking to find the next Jimmy, it's looking afresh at what we're seeing in front of us and not making assumptions. Steve, and then I'm going to move on.
So professional curiosity, I think, is absolutely the thing. But what that plays out like in practice, I think, is that it was only when he died that he became thought of as a victim. And actually, the hundreds of people who are out there will be seen every single day as part of the problem. And security staff will move them on, and the police will be asked to remove them, and they'll be abusive to our staff. And we're dealing with all of that, but we also need to be curious enough to understand what drives it. So we still have to work with security and safety for our staff, but we also have to ask the questions once they've been removed. That's I think where the Jimmys fall in between is because they're actually seen as the thing that's stopping us doing our job rather than part of the job.
That's such a powerful point for us to leave on. Thank you, Kirsty. Thank you very much indeed for coming in for that. Now, colleagues, we're running behind, so we're going to up the pace a bit. And there's a few papers where actually we've already discussed them elsewhere, and we know exactly what we're doing. So the next one up is safety and quality priorities from Jeremy. We've talked about this in about 7 different locations here. The thing I'm particularly pleased about is we've adjusted the priorities in the light of the comments from governors, the comments of subcommittees, etc. This is the final summary of it. It's the one slide up, isn't it? But we've got somewhere the safety quality improvements. We've got them on.
So we've added in prostate cancer. We've tidied up the experience ones, and so I'm very happy to take any further questions, but I've got my first round of the quality account where we're going to be saying these are our priorities if you seek to approve them.
Are there any final bites on safety quality priorities, or are you now happy to approve them? Approved. Moving on, thank you. Business unit. Paul, I've lost Paul. Yeah, we're running behind, Paul, just a warning. So, surprise, surprise. Terry, welcome also.
Thank you. So we were last here about a year ago, so I'm just going to really take the opportunity to just remind people about the services that sit within the business unit, run through issues, but really more focus on developments over the last year, just give you a chance to get up to speed with what we're trying to do, where we are, and take any questions after that. So just a reminder of the geographical patch. I think this probably affects our business unit more than anyone in terms of the breadth of coverage that we're trying to achieve, and our community sites, it's 107 of them. So one of our challenges is around how we work with, look after our teams and keep a good grip and keep a cohesive strategy to our services throughout that whole area. So that's how many staff we have, about 1,500. That's our budget. We work with the PCNs particularly very closely, and the local authorities too. We've worked quite hard, and I was looking back, I've been coming to board now, this is the 6th year of reporting about the business unit, and we've worked hard at our strategy and what we're trying to achieve. We've got quite an eclectic group of services, so trying to get a strapline and a focus on what all teams are trying to do has got us to where we are there. And we really are, I think, now motoring. I think that my first couple of years of coming here were very much reflecting on culture of the business unit and addressing issues. I think now we're at a point where the focus is much more on what are we achieving in terms of services and service development. So we split and are very focused on trying to look at our services in terms of planned care, which is very much about keeping people well and out of hospital and focusing on their quality of life, but also having unplanned services that can be there when they need them, to intervene quickly and avoid people going into hospital ideally, or if they do, minimise the stay or get them to the right part of the organisation. So these are the way we think about our services, and I include one or two services that don't sit within our business unit because I think we have to think across the organisation about those services that are crucial for managing people who are at home. So the ones on the right are the acute, unplanned bits, and the ones on the left are those that are aimed at keeping either our population well and healthy and thinking about well-being, or thinking about whether it's health or independence or mental health services and how they fit together. And underpinning all of that is our improvement work, so really trying to push where we are in terms of our workforce, in terms of digital, thinking about outcomes and training and development. And the complexities that arise are that obviously we sit within community services, but we work very closely with GP practices and with PCNs. So for each of our services, it's about trying to think through what level do we need to be operating at a practice level, or at a slightly bigger level, or at a North Tyneside or Northumberland footprint. So I'm not going to go through, but that's how we organise the business unit, just to make sure that we are watertight on our delivery. One of the things, just coming back to the big geographical spread of our teams, is trying to engage. And so we've done quite a lot of work over the last 2 years, and I know some of you have been at our celebration events, and we're delighted to use that for both internal work to showcase to us teams what each other are doing and what we can learn from each other, but also the rest of the organisation. We also do that through a regular newsletter. Because it's difficult, and I think Terry probably manages it better than I do to get out to teams. So these are ways that we can do it a bit more smartly. I'll just rattle through a couple of where I think we're at, but in terms of staff experience, we're doing well across the board really in most areas. The one on the right, the morale, is the one bit that I will highlight. And just looking at the breakdown of that, I think we are just starting to see issues around workload, and that's not a massive surprise because everything that you see mirrored in terms of activities is happening in the community, it's happening in people's homes, and although it may not be visible, our staff's caseloads and the complexity of those caseloads are getting more, the acuity is getting higher. So it's something we're very aware of. We also carefully watch our vacancies and our sickness levels too. Risks, and then I'm going to talk really about developments. They're very similar in some ways, the headings. So digitally, I think I've talked a lot about System 1's our major unit of organisation. I think that's improving, but where we really need to just ultra speed up is around our data and our outcomes and being able to show ourselves, but also the external world, the differences, or if there aren't differences that our services make. So that's a big project that needs to happen. And then we've got specific issues around particular systems. So Blythe Louis is our sexual health service IT system, which is really creaking and has caused some operational problems over the last couple of years. Estates within that, multiple different sites, the safety condition cost is very, very variable. So the community estate strategy is very welcome from our point of view. I know a number of you go out on visits to see But you can see that there are staff working state-of-the-art facilities. There are also staff where there are rats coming into the building, and there are things that are not acceptable, and I think if they were in a hospital site wouldn't happen. So that we're on top of. The estate strategy will deal with some of those things, and just got some examples of particular areas which are very important at the moment. Touched on workloads. By and large, I think all our services are in a good state, bar a couple, and both OT and wheelchair services are struggling with staffing levels, and that means that their performance is not as good as it could be. And because everything connects up in terms of multi-professional teams and keeping people well and keeping people at home, those are areas that we're really trying to tackle, and I'll talk about how in a second. I also just wanted to flag safety. I've mentioned estates, but I think we're increasingly finding, and it's interesting, I think the headlines today are around schools and pupil violence. We're finding it from patients, and that's abusive, it's inappropriate behaviour, it's sexually inappropriate behaviour, and that is on the rise now. So we're just having to support staff a lot more and think about safety and those aspects. Safety has always been a potential issue when you're into people's homes, but it seems to be more of an issue now. Our cost improvement, I think we've managed over the last few years to deliver on that. It's becoming harder, and I think there's that balance between shifting services, and I'm happily sitting next to Paul here. I'm about to say that of shifting services out into the community while balancing cost improvements, and we've managed so far, but it's a pressure point for us. On workforce then, just to touch on vacancies, I showed a slide last year which was about community nursing and really what we've done to try and build a career ladder. We're doing the same with occupational therapy. We're stretching our banding, so we've got our nurse consultants and look at joint posts with NPC and the business units.
Paul, I'm just going to cut in because you've got a lot of stuff that I really want us to hear.
Yeah.
But you've already used your 10 minutes. I think we need to look at a rescheduling. We need to take some questions on where we've got to, and we need to reschedule to invite you and Terry back to talk about the next generation of services. I don't want to just rattle through them and ignore them, but nor can we give them the time this morning that it deserves. Unless there's a couple of summary comments, then I'll take some questions or comments from the floor, and then we'll come back for the next.
Yeah, I suppose just to say, I think we have got some really fast developing services, so particularly around virtual wards and our unplanned services, those now we're sharing nationally. People are interested in what we're doing, and we are fast leading in those. Perhaps some of those other services we'll come back to really in terms of just innovative ways of accessing the services. I think it was one of the things that I would share.
I would really welcome us having time to do some proper digging on that, which means not today. Marion?
Yes, and I think we would all welcome that, because I think the community business unit have come on leaps and bounds.
Leaps and bounds.
And it's about the integration, particularly of our other business unit members here. I would like one thing to say about the things that aren't working.
Speak into the mic a bit more.
It's Shire, but we need to get that sorted out. I know there's been various meetings, but I know that you're very keen as well to get an update about that. Hopefully David will give us one, and the team today.
We'll get some. Are we receiving a further update from Damien and?
I've asked for one.
Good, thank you. Thank you. We'll make sure of that. Richard.
So just picking up on that one, because I think those of us at the Assurance Committee who got to experience the full concerns over Sharma were quite shocked. I guess at some stage it'd be nice to have a wider view of the community estate, the good and the bad and the ugly, so that we can take it. I think we understand our hospital estate in considerable detail. I think I feel less confident I understand the state of the community estate, and I think it's worthy of a follow-up discussion.
You'll probably say the same thing, Veronica, but at least we've got a process now.
Yeah, with NHFM taking over community estate, there's already been quite a lot of work done to do that sort of initial audit of exactly where are we at with this and where are the priority areas, and over the course of the next 12 months we'll be looking at that in more detail and hopefully from that and pulling out the prioritisation. Obviously Shine was already up there and that's on the agenda today and David will pick that up. But we'll be looking at prioritising beyond that within it about what needs to be done, really understanding where the issues are.
Okay, then forgive me for cutting this short. There's plenty of evidence of real, quite dramatic progress in community services over the last year. There's some very specific short-term problems around Shiremore, which we will be looking at in private board later on. We're getting an update. I understand there's some wider issues around community estate that are now in hand, and NHFM is starting the process over the next few months of properly reviewing that. And we will make some time to look properly at the next stage developments and how they fit with the clinical strategy. And I'm sorry, Tony, for having cut you and Paul short. So thank you very much indeed. Now we're going to move on. Colleagues, it's already 12 o'clock. I need your leeway. It will take us through. We've still got 10 minutes, 10, 15 minutes. You know what the brief is, Ross?
I was going to say, very conscious of time, Chair, and this is quite a lot of information in here. I'm sure people have seen it, so I'll just present it to the board and well, many questions. It's quite timely because you've seen all the headlines around the BSA public perception survey on Monday, so I hope to provide a bit of reassurance and assurance around all the many things we're doing around communications and engagement to help drive up that reputation.
Thank you, and thank you for the brevity. Questions or comments? Are we happy to receive the comms engagement? We've got lots of nice stuff in this. I love seeing it. Yeah. Thank you very much indeed for that. Gender pay gap, Kate.
Thank you. So this has gone through People and Culture Committee, and two main points just to mention really is that it's going in the right direction in terms of our gender pay gap, and we've made a decision through People and Culture that we will report on this now quarterly through the subcommittee board so that we can be more proactive with the actions and the improvements associated. I would just draw the board's attention to the two dashboards for the Trust and the NHFM. I think they're very informative and give the detail that the board requires, and like I say, there's slight improvements on both NHFM and the board, and NPC from next year will also need to start to report on gender pay gap because they've hit 500 employees.
And we also have the assurance that People and Culture is pouring all over this. Yeah. In the knowledge that it's being chewed over by People and Culture, are there any other questions or comments people want to make? Happy to receive the gender pay gap reports. Thank you. Item for escalation from the board committees, nursing and midwifery assurance support panel. We're being asked to review and note. Nothing exceptional coming through from that. Content to review and note. The learning from desk, Jeremy?
Yes, so I'm very happy just
Been through all the necessary steps. Here's the final point. Are we happy to note the report? We are indeed. Corporate safety and quality, Chris?
So this came to FIP on Monday, so there's nothing further to add from FIP. Difficult, challenging period, but we've managed to maintain good level of performance across the key metrics.
Again, this has been chewed over in a lot of places. Final questions or comments before we note this in board? Thank you. And the corporate financial compliance support, Paul?
Thank you, Chair. Just to confirm, fully online on target to deliver all financial targets this year, as discussed on Monday.
Very good. So once again, we're confirming the conclusions that FIP has reached. Any extra points the board want to make? Then we're happy to receive and confirm. Thank you. We've got the agenda for the next meeting. Any points? Look pretty straightforward. Another draft quality account, which we want to put some time in, maybe more than 5 minutes for. Yeah. Okay. How does it go? The meeting? Run over for 5 minutes. Apart from that, All okay? Yeah, meeting what you're expecting, what we're expecting. I think we have no questions from the public today. And thank you very much indeed, colleagues, for we are reconvening in about 20-25 minutes in private. Thank you very much indeed.